Hi, everyone. Thank you for joining us today. Welcome to the Healthcare Associated Infections and Antimicrobial Resistance webinar series. It is 2 o'clock or a little bit after, so we will go ahead and get started. My name is Hannah Gallion. I am the Antimicrobial Resistance Epidemiologist at the Indiana Department of Health, and I will be leading today's webinar. We have set aside some time at the end of the webinar for question and answer. Please put your questions into the chat box throughout, and we will get to them at the end. Today's webinar is the last in the first series of webinars that were sent out back in August. Previous webinars were recorded and they can be viewed at the link in the box. You can also get a copy of the slide sets for each webinar on that page as well. Additionally, a recording of today's webinar and the slide set will be made available at this link. The slide should be up by the end of the day, and then the recording is usually up about a week later. Here is a schedule of the webinars that we have set for the rest of 2022. The calendar invite was updated this afternoon to extend the reoccurring meetings. You likely got an email when that happened with the extended dates. Just like this series, we'll be doing a Microsoft Teams meeting. It will use the same link that we've been using. And we will also be recording those and putting them on the website. If you do not have the calendar invite or would like to be put on the distribution list, you don't get reminder emails, please send me an email and I will get you added to that. With that, we will go ahead and get into today's topic of multi-drug resistant organisms. This first slide is just to show you our mission and vision here at IDOH. Today, we're going to go through a few definitions related to multi-drug resistant organisms, or MDROs. We also will talk about antibiotic resistance, antibiotic resistant organisms, and then different infection control and prevention strategies that you can take at your facility. And again, at the end, we will be able to answer any questions that you may have. So first, an MDRO is any organism that is resistant to one or more agents and at least 3 classes of antibiotics. It can also be anything that exhibits a classification of resistance that is of epidemiological concern. So an example of this would be MRSA or carbapenem-resistant enterobacterales. I also want to talk about carbapenem and carbapenemase because this is something that we will touch on again later in the presentation. So carbapenem is a class of antibiotics and often thought of as the last line of defense. Carbapenemase is an enzyme that is produced by the bacteria, and it breaks down carbapenem antibiotics. Carbapenemase is a resistant mechanism that the bacteria can use in defense against carbapenem antibiotics. Getting into antibiotic resistance, there are 2 different types of resistance, both intrinsic and acquired. Intrinsic resistance means that the organism is naturally resistant to the antibiotic mechanism of action. So, for example, gram-negative bacteria like E. coli are intrinsically resistant to vancomycin. Acquired resistance is often genetically passed, either vertically or horizontally. Vertical gene transfer refers to the transfer of genes as bacteria multiply. So once a bacteria multiplies and divides into two bacteria, both bacteria carry the gene. An example of this could be porin size. So if a single bacterium has a slight mutation that makes a porin slightly smaller, the antibiotic cannot enter the cell, and therefore that bacterium does not die. Once that bacterium multiplies and divides, it passes that gene for the smaller porins onto the new bacteria. Horizontal gene transfer can occur when bacteria carry a gene for an enzyme on a plasmid. This plasmid, with the antibiotic resistant gene, can then be transferred to other bacteria in the area. It can even be transferred to a different organism. An example of this would be the carbapenemase genes. This slide is just a visual representation of what we just discussed. Steps 2 and 3 show intrinsic resistance or vertical gene transfer, depending on the natural resistance of the organism. Step 4 shows the horizontal transfer from one bacteria to another. There are 5 resistant mechanisms that are often seen in bacteria. The first is a penicillin binding protein modification. Penicillin binding proteins are involved in the development of the cell wall, and antibiotics can target this as an active site. Bacteria can then modify that penicillin binding protein and confer resistance to the antibiotics. A second mechanism is porin mutations, which I talked a little bit about before. Porins are found in the cell wall and are used to help transport solutes in and out of the cell membrane. Mutations in porin size can cause the concentration of antibiotics needed or the dose needed to increase in order for the antibiotic to be effective. A third mechanism is efflux pumps. These are found in different organisms and they actively remove antibiotics from within the cell wall. A fourth mechanism is antibiotic target changes. These occur as a result of point mutations in a specific gene and prevent the antibiotic from attaching within the cell. The last resistant mechanism is enzymatic inhibition. This is the most common mechanism of antibiotic resistance. Enzymes produced by the bacteria can change the chemical structure of the antibiotic. Examples of enzymes include penicillinases, extended spectrum beta-lactamases, and carbapenemases. This graphic from the CDC shows how antibiotic resistance can spread. It is important to remember that antibiotic resistance can be affected by everything in the graphic, including animals. However, at a facility level, you are likely more interested in the right side of the graphic with George. George was prescribed antibiotics and later developed a resistant bacteria. George may stay home and not need further care, but he can continue to spread the bacteria to those in his community. George may seek care at a hospital or other healthcare facility. There, the bacteria can be spread to other patients, either through direct contact, indirect contact through unclean hands of healthcare personnel, or through surfaces in the facility. I also want to talk a little bit about antibiotic stewardship. The Association of Professionals in Infection Control and Epidemiology define antibiotic stewardship as the practices dedicated to improving and optimizing antimicrobial selection, dose, and duration while minimizing patient harm. The CDC has issued core elements of antibiotic stewardship programs for hospitals, long-term care, and outpatient settings. These core elements can be used to guide efforts to improve antibiotic use. The core elements lay out the primary necessary components of a successful antibiotic stewardship program. For hospital programs, the core elements include leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. The CDC also has additional implementation guidance for small and critical access hospitals. Both core elements and implementation guides can be found on the CDC website. Please feel free to reach out if you have additional questions about antibiotic stewardship. We will now move into antibiotic-resistant organisms. In 2019, the CDC published the Antibiotic Resistance Threats in the United States report. This document goes through the threat of antibiotic resistance as well as pathogen summaries. Threats have been broken down into 4 lists, which include urgent threats, serious threats, concerning threats, and a watch list. Today we will talk about vancomycin-resistant enterococcus, or VRE, vancomycin-resistant Staphylococcus aureus, or VRSA, Clostridioides difficile, emerging resistance, including carbapenem-resistant Acinetobacter and carbapenem-resistant Pseudomonas. We'll also talk about carbapenem-resistant Enterobacterales, or CRE, and carbapenemase-producing organisms. Although this list seems extensive, it does not cover all of the organisms that are listed in the U.S. threat report. VRE is listed as a serious threat in the report. Enterococci are normally found in human intestines. Nearly all VRE infections happen in patients with healthcare exposures. It can be transmitted person to person and also through the environment through contaminated surfaces or equipment. From 2012 to 2017, the number of VRE infections decreased. However, VRE is increasingly resistant to additional antibiotics, making treatment difficult. VRSA was removed from the U.S. threat list in 2019 due to a low number of cases reported. To date, there have been only 15 infections reported in the United States. The most recent was in May of 2021 in Michigan. To date, all isolates have been found to have the VAN-A gene, which is commonly found in VRE. Risk factors for VRSA include underlying health conditions, catheter use, history of MRSA infections, and recent exposure to antibiotics. VRSA is reportable in Indiana. However, we have not had any cases to date. C. diff is currently listed as an urgent threat on the AR threat report. C. diff infections are more common and more severe in older adults. There were 224,000 estimated cases in hospitalized patients in 2017. Patients diagnosed with CDI should be put on contact precautions. Strategies to reduce CDI infections should include improving antibiotic use, infection control, and healthcare facility cleaning and disinfection. Moving into emerging resistant organisms, We have both carbapenem-resistant Pseudomonas and carbapenem-resistant Acinetobacter. These organisms are not currently reportable in Indiana, but we still ask that you send reports of these organisms so that we can continue to track them. These reports can be sent through MBS and a morbidity report or faxed using our secure fax line. Multi-drug resistant Pseudomonas aeruginosa is currently listed as a serious threat in the AR threat report. Pseudomonas is commonly found in the soil and water. However, it can cause infections when it is entered into the blood, lungs, or other parts of the body. Carbapenem-resistant Pseudomonas aeruginosa, or CRPA, can also colonize on patients, meaning they can have the organism without showing any signs of infection. We are particularly interested in carbapenem-resistant Pseudomonas, as these organisms are likely resistant to nearly all antibiotics. Additionally, 2 to 3% of CRPA carry a mobile genetic element for the carbapenemase enzyme. This mobile element is called a plasmid and can be easily shared between bacteria. CRPA can easily spread person to person through contaminated hands, shared equipment, and contaminated surfaces. The CDC has put out a containment strategy to stop the spread of these infections. This strategy includes rapid identification, infection control assessments, colonization screenings, coordinated response between facilities, and continued assessment and screenings. Patients at high risk for CRPA include those that are ventilator dependent, those with invasive devices such as catheters, and those with wounds. Carbapenem-resistant Acinetobacter baumannii is currently listed as an urgent threat on the AR threat report. Acinetobacter is commonly found in soil and water, however, can cause infections if found in the blood, lungs, urinary tract, or wounds. A patient can become colonized with Acinetobacter without causing infections. Like CRPA, CRAB, or carbapenem-resistant Acinetobacter, can also carry a plasmid with a carbapenemase enzyme. These plasmids are easily transferable to other bacteria. CRAB is often spread person to person through the hands of healthcare personnel or family members, contaminated surfaces, and shared equipment. It can persist in the environment for prolonged periods, which enables transmission through contact with contaminated surfaces. Patients at risk for CRAB include those that have had recent healthcare exposures, those on ventilators, those with invasive devices, and wound care patients. Carbapenem-resistant Enterobacterales, or CRE, are currently listed as an urgent threat on the AR threat report. Enterobacterales are a category of bacteria that live in the GI tract of humans. Examples include E. coli, Klebsiella species, Enterobacter species, and many others. CRE are any Enterobacterales that is not susceptible to a carbapenem antibiotic. They can be resistant to carbapenems through several different resistant mechanisms. However, carbapenemase production is currently the most concerning resistant mechanism. This is due to the carbapenemase gene being found on a plasmid, which can be horizontally transferred from organism to organism. Risk factors for CRE include recent healthcare exposure, medical procedures, or use of invasive devices. Additionally, recent antibiotic use and prior history of MDROs can put a patient at higher risk of a CRE infection or colonization. Patients can be colonized with CRE without an infection. It often colonizes in the gut, but can cause infection if it enters the respiratory tract, urinary tract, or found in the wounds or blood. As I stated earlier, carbapenemase production is currently the most concerning resistant mechanism for CRE. If a CRE produces a carbapenemase enzyme, we refer to it as a CpCRE. In the United States, approximately 30% of CRE carry a carbapenemase. In order to determine if a CRE is carbapenemase producing, labs can run two different types of tests, either a phenotypic test or a genotypic test. Phenotypic test examples include a modified Hodge test or a modified carbapenemase inhibition method, or MSIM test. These will result in either a positive or negative result. Genotypic tests often look for carbapenemase gene markers. Examples of those include KPC, VIM, IMP, NDM, and OXA. Gene markers often vary by location. In the United States, KPC is the most commonly identified gene marker. However, it is not the only one found in the United States or in Indiana. CpCRE are reportable in the state of Indiana. In 2021, there were 179 reported cases. Here you can see the breakdown of different gene markers. As I said, KPC is the most common gene marker found in CRE across Indiana. You may also notice that about 2% of isolates are marked as novel or unknown. These isolates were either found to be genotypic positive and phenotypic negative, meaning none of the 5 gene markers were detected, or the isolates were found to be resistant to 3 carbapenem antibiotics, but tested negative for both genotypic and phenotypic tests. This slide shows a breakdown of CpCRE cases by health district in Indiana. Please take a moment to find what district your facility falls under and see how many cases were reported in your district. As I mentioned earlier, both CRPA and CRAB can also have carbapenemase production. Like CRE, we refer to the carbapenemase producing organisms as CpCRPA or CpCRAB. The carbapenemase can be detected through the same testing methods as CpCRE. The same gene markers are also tested for. Lastly, we will move into some prevention strategies that facilities can use. There are a lot listed here on this slide, but today I'm going to specifically touch on those with a yellow star next to it. Hand hygiene is an important step in preventing MDROs from spreading in a facility. When caring for patients with MDROs, healthcare personnel should follow standard hand hygiene practices. Wearing gloves is not a substitute for hand hygiene. Alcohol-based hand sanitizer is effective against most MDROs and can even be used when caring for patients with Candida auris. However, when caring for patients with C. diff, soap and water should be used instead of alcohol-based hand rub. Contact precautions should be used on all patients infected or colonized with a novel or targeted MDRO. The CDC has set type and duration of precautions in Appendix A of the CDC Guideline for Isolation Precautions. When caring for a patient under contact precautions, you should be using gown and gloves. These should be discarded between patients. Dedicated or disposable equipment should be used for these patients. If you are not able to use dedicated or disposable equipment, then equipment should be cleaned and disinfected before use on another patient. It is important to note manufacturer's use of disinfectants when using on equipment. Interfacility communication is important so that receiving communities and facilities are aware of what is needed when caring for a patient. Having an interfacility transfer form that travels with the patient can ensure that the receiving nurses at the facility are aware of the needed PPE. IDOH does have a transfer form that is seen here on the slide that can be used not only for MDROs in Candida auris, but for other infections as well. I also want to mention patient and staff cohorting. Patients with the same MDRO can be cohorted and placed in the same room. It is important to cohort by organism and not just MDRO status. Additionally, you may need to cohort by more than one MDRO. For example, if you have 2 patients with Candida auris, but one also has a CPCRE, you would not want to place them in the same room unless absolutely necessary. With single rooms, you can also cohort within the unit by placing patients with similar MDROs near each other. This helps to limit the staff that are seeing each patient. As I have stated, some MDROs can colonize on the patient and can still be spread. Colonization can occur without the patient showing any symptoms. To stop the spread from colonized patients, it is best to know which patients are colonized and then place them under the correct contact precautions. CPCRE colonization can be detected through a rectal swab screen. IDOH currently recommends that roommates of patients found to have a CPCRE be screened. Additionally, we may recommend an entire unit be screened if the index patient was not under transmission-based precautions. The graphic on the slide shows the swabs that are used during the screen, as well as how to swab the area and how to place it into the proper container. Some of you may be familiar with IDOH's screening process and the Antimicrobial Resistance Lab Network, or ARLN, if you have participated in a CPCRE or Candida auris screen. If you are participating in a screening, kits can be shipped directly to your facility. After the swabs are collected, they are then sent to our ARLN regional lab in Wisconsin for testing. Results will then be faxed to your facility, and you will receive a follow-up call from our team at IDOH. This process is free to the facility, and our team is happy to help with logistics throughout the process. I want to thank everyone again today for joining us, and at this time we will be able to take any questions that might come through the chat. That is not something that I have available right now, but it is something that we will keep in mind as we continue looking at these cases and looking into our 2021 data. I will have to check specifically about CLIA approval. I do know that modified project is not one that is generally recommended because there are specific organisms that will show positive on a modified project test without actually showing or having carbapenemase production. DJ, I can get back to you on the CLIA approval for it. But like I said, I do know that enzyme tests are recommended over a modified test. I was just going to repeat the first couple of questions that I had answered. So Scott Steinecker had asked about rates per 100,000 population. Those are things that we can look into in the future, but we don't have those numbers right now. And then DJ had said he was under the impression that modified Hodge tests are no longer CLIA approved / recommended phenotypic test. Has this changed again? And then Rachel asked how long should patients stay in isolation for the various MDROs? So for CP, CREs, and Candida auris, I know I didn't touch a ton on Candida auris, but for both of those patients are under contact precautions indefinitely. So anytime that they come into the facility, for some of the other MDROs, it would be best to look at the Appendix A, the guidelines from CDC. If you have a question about a specific MDRO, I would be happy to look into it and get back to you on one of those. Carolyn asked who's isolating CRE that are not CP. Carolyn, I can try and answer and you can let me know if this answers your questions. I know a lot of times labs will isolate Enterobacterales that are carbapenem resistant. So they have isolates that are considered a CRE. And then once they have that isolate is when they usually will do a carbapenemase test. And then they'll test specifically for carbapenemase production, which could make it a CP CRE, or it could just be a CRE. Okay, and then so Tiffany was asking, do CRE not need to be isolated indefinitely? And Carolyn, I see now that you're asking about contact precaution isolation. So yes, CRE and CPCRE would need to be isolated under contact precautions. I don't see any more questions in the chat. We will stay on for the next 5 minutes or so until 2:45. If you guys have additional questions, feel free to throw those in the chat and we will get to them. But otherwise, we will just sit and look for additional questions. Thank you again for joining us today. I saw Elizabeth asked about if slides will be available. Yes, they will be. I will throw, or Caleb, throw the link to the webpage into the chat. That way you guys can see those. And they'll be up later this afternoon. Hi, Rachel. I saw you had asked about Elizabeth Kingia. This is not an organism that I am familiar with off the top of my head. If you send me an email with your question, I will get back to you within the next day or so with an answer for that.